we're really using these in many types of malignancies, but you can see this class of drug, these monoclonal antibodies, the small molecule inhibitors being used in colorectal cancer, ovarian cancer, renal cell carcinoma, brain cancers, hepatocellular, non-small cell lung cancer, gynecologic, oncology, malignancies, so lots of different types of cancers where we're seeing these drugs used.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Danielle Roman, Manager of Clinical Pharmacy Services at Allegheny Health Network Cancer Institute in Pittsburgh, Pennsylvania, about the VEGF inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome. Thanks so much for joining us again today, Danielle.
Hi, Jaime. Thanks for having me.
All right. So to start off, could you give us a brief overview on the history of the VEGF inhibitors in the field of oncology?
VEGF, we'll just start there. VEGF stands for vascular endothelial growth factor inhibitors. This is a class that has probably been investigated, I'd say, the last 30 years or so. We had our first drug approved in this class in 2004. So about 20 years or so of experience with using these agents. Just a little bit of background on the thought of why these drugs would work in the first place. Cancer cells are known to secrete factors that cause the formation of new blood vessels. And tumors need blood vessels to supply themselves with nutrients so that they can grow and metastasize. And a lot of tumors overexpress these factors. So they have more of this ability to create new blood vessels. You may hear that term somewhere, neovascularization. So that is just a really long term for the process of making new blood vessels. And also, these factors can increase the permeability of blood vessels, so making them kind of leaky blood vessels. So it was known that tumors could do this. So the thought behind it is being able to block the ability for these new blood vessel formation and to decrease that leakiness or permeability of those blood vessels. So I mentioned we had the first drug approved in 2004. Likely many people have heard of this drug, bevacizumab. We now have many biosimilars of that product available. And then we'll also briefly touch on some of the oral drugs that are inhibitors of this VEGF class. And the first one we had approved there was sunitinib, and that was in 2006. And shortly after we had the IV, we had oral options as well.
Thank you so much for that historical overview. It seems like only yesterday that these came out, but as you said, these have been around really for quite a long time now. So thank you for giving us sort of that perspective. Let's talk a little bit more in detail about the actual mechanism of action. How do they work?
So we said VEGF really drives that blood vessel formation or angiogenesis. So these drugs are inhibitors of that, and we can see them working in a couple of different ways. Some of these drugs actually target that VEGF growth factor without these inhibitors in place. So what happens is that we have VEGF that binds to a VEGF receptor that's on cells. So that could include cancer cells. And when that binds, then we can see it cause within the cell a series of downstream signals to cause that cell to produce those blood vessels and, become more permeable or leaky. So these drugs block that process, and they can do it either by binding to that VEGF growth factor, prevent it from being able to bind to the receptor, or they can actually bind to the receptor itself and block VEGF from binding. So kind of in really two major places where we can see that happening. There are a couple different VEGF receptors you may have heard of. So VEGF 1, 2, or 3 are just different VEGF receptors out there. And so there's some differences in the binding of these drugs within the different receptors. But overall, the goal here is decreasing the formation of those new blood vessels within the tumors and decreasing that permeability of the blood vessels, so that leakiness of the blood vessels. And by strengthening those blood vessels there, we get better delivery of chemotherapy within the tumors.
That's really interesting. I mean, that secondary component, I always knew about the angiogenesis and all of that, but being able to sort of tighten up those blood vessels, and that does help improve that delivery of the other chemotherapies that are likely being prescribed along with it. So really interesting. Thank you for sharing that. Let's talk about sort of testing that goes along with patients who are receiving a VEGF inhibitor. Is there any biomarker testing that as nurses we should look for or anticipate if someone is going to be eligible or prescribed a VEGF inhibitor?
It's a great question because a lot of the drugs approved now do have different biomarkers that we need to be looking for. But this class is not one of those. So we don't need to look for any particular VEGF overexpression or any kind of mutation with these agents. So really nothing to report here with that.
Always good to ask, though. Like you said, it's uncommon in that way. And so it would be normal to expect that, but it's interesting and nice to know that that's one drug where we don't have to worry about that. Let's talk a little bit more in depth about the actual class itself and the specific agents within that class. Can you describe some just examples of the VEGF agents that we are seeing? And are they divided into like subclasses, or are they just still all considered under one main umbrella?
Yeah, so I would say they are divided out. I would divide them out into three classes that we'll briefly mention here. But within those three classes, I would say I'd put them into two buckets. So the first bucket is those agents that work outside of the cell. So they're blocking events that are happening on the cell surface before it can signal the downstream parts that happen inside of the cell. So within that extracellular, outside of the cell membrane, one of those subclasses is the monoclonal antibodies. The first approved agents falls into this area here. That's bevacizumab, so that's binding to VEGF. And then our other monoclonal antibody here is called ramucirumab, and that is one that targets that VEGF receptor. The next subclass would say it's also acting extracellular outside of the cell, and this is an agent that's called aflibercept. And this is a little bit different from the mechanisms of the monoclonal antibodies. And I think it's kind of a pretty interesting mechanism. We call it a VEGF trap because it's trapping VEGF. So this is a fusion protein molecule that really acts as a decoy receptor. So it's sort of acting like VEGF, and it's binding and neutralizing that VEGF growth factor. So kind of using it up so it's not able to bind to the VEGF receptor. So that is kind of another subclass there with that, just that one agent, aflibercept. And then the third subclass falls into that second bucket. And these are drugs that are tyrosine kinase inhibitors. These are oral small molecule drugs that are acting intracellular. So they are working within the cell to bind and prevent that downstream signaling of producing more blood vessels. So we have a number of small molecule drugs that fall into this class. Many of them target multiple types of receptors, VEGF being included, but also a lot of these drugs have other targets. So some examples of these that target VEGF and other targets would be drugs like axitinib, cabozantinib, lenvatinib, pazopanib, sunitinib and sorafenib, fruquintinib, regorafenib, and vindatinib. So they're all ending in that nib. You can identify them as the tyrosine kinase small molecules. And then we have just one more to mention. This is the newest approval in the class, tivozantinib, and this was approved in 2021. And this is also tyrosine kinase inhibitor small molecule drug, but a little different in that it's more pure for its effects on the VEGF receptor. And it blocks all three of those that we mentioned before, the VEGF 1, 2, and 3. It has its effects on all of them. So that's kind of the big overview. And we're really using these in many, many types of malignancies, mainly solid tumor malignancies. But you can see this class of drug, these monoclonal antibodies, the small molecule inhibitors being used in colorectal cancer, ovarian cancer, renal cell carcinoma, brain cancers, hepatocellular, non-small cell lung cancer, gynecologic oncology, malignancies, so lots of different types of cancers where we're seeing these drugs used.
Wonderful. Thank you for that overview. So it sounds like if you're caring for patients who have diagnoses that are solid tumor in origin, then likely you've encountered at least one of these VEGF inhibitors that you've mentioned already. So a very broad class, which is unlike some of the other ones that we've talked about, where it does seem very specific because it is that sort of biomarker-driven type of therapy. Since you've just described, we have some that are in an IV sort of infusion version and some are oral agents. Can you touch briefly on just some of the administration considerations that nurses should keep in mind when we're caring for patients that are receiving VEGF inhibitors?
Yeah, so just a few kind of high-level things. There are a lot of nuanced, very specific things with each of these agents. But if we look high-level at the drugs that we're giving IV, so there's the three of them, bevacizumab, ramucirumab, and that VEGF trap agent, aflibercept. So these are all agents that, again, are given IV. They are dosed milligram per kilogram. And these drugs are ones that have the potential for hypersensitivity reaction. I would say generally this is a lower risk than we see with other monoclonal antibodies, but something to keep in mind. So particularly with bevacizumab and ramucirumab, we do give the first infusion over a longer period of time. And then if well tolerated, can decrease the infusion time. So with bevacizumab, really the most common agent used within this class of drugs, the first infusion is recommended over 90 minutes. Then we can go down to 60 minutes if well tolerated, and then down to 30 minutes for subsequent infusions. And there is, just to mention, some data on giving rapid bevacizumab infusion. So some institutions may be giving it over a shorter time period. Ramucirumab has a 60-minute and then goes to a 30-minute infusion. Aflibercept, our VEGF trap agent, is given over 1 hour, and that's kind of consistent across infusions. And these are drugs that are generally given on an every 2 to every 3 week basis, depending on the regimen. And I will just call out with ramucirumab monoclonal antibody, this is recommended to have a pre-medication of H1 antagonist, so generally diphenhydramine, that's administered as a pre-med with this particular one and not so much needed with the other ones. And then with our tyrosine kinase inhibitors, these are our oral medications. I would just point out here that there are a variety of different dosing schedules that are used, daily, twice daily, different schedules of being given continuous versus giving for a period of time with some days off in the cycle. Some need to be given with food or without food. So just kind of highlighting that there are a lot of nuanced pieces with those oral agents, and it's good to always refer back to a drug information source such as Lexicomp or the prescribing information to see the particulars with that.
Great. Yeah. And I really appreciate you calling out the dosing of the IV, the infusion agents as milligrams per kilogram, which is not common or not as usual in, at least adult oncology. We usually see that in, of course, based on BSA or AEC or any sort of unique thing, but not typically the very basic milligrams per kilogram. So this isn't a unique drug class in these IV agents that do utilize that. So just something to watch for when doing the dose verification steps as part of that infusion. Let's talk a little bit more about now the side effects, these toxicities that we could expect to see or should be mindful of for these patients. Can you talk about them both, if there's uniqueness in any individual agent or if there's some broad toxicities that span the entire class?
We'll first start with some of the broad toxicities to watch for here. I would really say number one, something that we very commonly see with this drug class is hypertension. Giving you an example of bevacizumab, if we look at any grade hypertension, this can be up to 67% of patients. So very common toxicity, really spanning all of these agents. So something that we need to be monitoring closely for. Also, there is kind of a broader cardiovascular risk here with a smaller potential for something like congestive heart failure. This may be secondary to hypertension and something that is usually reversible with treatment, but not nearly as common as what we see with hypertension. Other things from a class effect to mention is that there is thromboembolic events. So really important counseling point for patients. We can really see kind of the spectrum of what happens here with venous events like a DVT or a PE. Also can see arterial thromboembolic events, so stroke and MI. And this really could be because of the effects of VEGF causing a prothrombotic state within the body. So we know our patients are often at higher risk just from their cancer diagnosis. And this drug class can put them at higher risk for having a thrombotic event. And then converse to that, we can also see patients have a bleeding risk. So thinking about the way that these drugs work on blood vessels, there is an increased risk of bleeding and hemorrhage that can happen here. Most commonly, we see this in something like epistasis. We can see an increased risk of this for patients that are on anticoagulants. So not a contraindication necessarily, but certainly something that we want to watch for with patients receiving these drugs class and in counseling. Patients on reporting bleeding. We can also see some wound healing complications. Again, if we think about the way these agents work on blood vessels, it can impact patients' ability to heal. So it is recommended for these agents. Really important to look at the particular agent to see the recommendations, but I'll give you an example for the monoclonal antibody class. So with bevacizumab is a good example of that. It's recommended that patients have any elective surgeries delayed by at least 4 weeks from their last dose. And then you'd want to wait at least 4 weeks after surgery or until the patient is their wounds have fully recovered before restarting the agent. And this is because there is a long half-life of the drug, so it stays in the body for a really long time. So important consideration as we think about maybe our patients that are getting this in a setting where they may need to go to surgery eventually. So ovarian cancer, colorectal cancer, we need to be giving adequate time for holding the drug before and after a surgery. And then a rare chance for gastrointestinal perforation. It is rare, but something that we could see a little bit higher risk with ovarian cancer and important to counsel patient what to watch for there. And then I just want to briefly mention a little bit of specifically. So that was kind of as a class effect, I would say the GI perforation component, a little bit more common with the IV agents. And then with our oral TKI agents, there are some unique things to watch for here. So a greater chance of having GI toxicity with diarrhea or stomatitis, greater chance of fatigue, potentially hand-foot syndrome that we can see with some of our drugs such as sunitinib or sorafenib, axitinib. And then some more unique things we can see is some skin and hair depigmentation. So hair can actually turn white with drugs like pazopanib or sunitinib. And then some dysphonia or hoarseness that patients can develop when they're on these drugs. That's changes to the vocal cord that can happen. Some examples of drugs this can happen with is axitinib or tivozanib, and some thyroid issues that could occur there. So making sure we're monitoring thyroid with these tyrosine kinase inhibitors. So some toxicities that we're familiar with managing in oncology, but also has some pretty unique things as well.
The changes in voice, that would be one that, I would not expect. And then certainly patients would probably be surprised if they weren't aware and kind of just monitoring for that. So thank you so much for mentioning some of these more unique ones. Let's move on now to strategies to manage some of those toxicities that you just mentioned. Can you share some of the evidence-based strategies that we know we can use to help manage those toxicities?
One I mentioned, the most common one we see is hypertension. I think this is something many of us are very familiar with monitoring and some degree of management here. But blood pressure monitoring is required. For patients getting the IV agents, we would want to do this prior to each infusion. For the oral agents, there are very particular blood pressure monitoring that's recommended for each of these. But generally, especially when patients start these agents, we're going to have more intense monitoring because we can see this toxicity early in therapy. We want to make sure that patients have their blood pressure controlled at baseline. So if patients have uncontrolled blood pressure initially, certainly as we start these agents, we're likely going to worsen that. And it is, especially with the oral agents, it is not uncommon for patients to need to start an antihypertensive while on these, or maybe need an increase or additional antihypertensive therapy if they have been on something previously. We see this a side effect with patients that are getting higher doses or longer durations of treatment. So just things to keep in mind here. Some other things to think about with treatment of hypertension, our ACE inhibitor class is usually the one drug class that we're reaching for as one of the primary therapies here, or potentially also our calcium channel blockers, such as amlodipine. But generally, we're trying to avoid verapamil and diltiazem because of drug interaction. So just a little call out there with those. But really, any of the antihypertensive class could be used here. Another monitoring strategy, and something I forgot to mention as a side effect we're watching for, is proteinuria. So we can see patients have excretion of protein in their urine. So this is often another part of therapy, and certainly as a frontline staff, something that we are needing to counsel patients that we're going to be monitoring and something that we're carrying out as we have patients on these treatments. So this is usually with a urine dipstick for patients that have elevated protein in urine dipstick, so usually a 2+ or greater. This requires a 24-hour or a suggested 24-hour urine collection. for then looking at that total protein in 24 hours and making decisions on whether we need to hold therapy or make any additional referrals for our patients. I mentioned the rare GI perforation that could happen here. So counseling patients and watching for any signs of abdominal pain, fever, vomiting, anything significant like that that could indicate an issue that's going on in the GI tract. And then with that impaired wound healing, so keeping that in mind as we are planning for this agent for patients, and even sometimes with the minor surgical procedures or maybe a need for a short hold, and even for something like a catheter placement. I know in some providers I work with have a preference for holding for a short period of time around that as well.
Great. Thank you so much for sharing all those great strategies. Certainly a lot to think about, but a great job of helping to summarize that. Knowing now all that information, that great information that you've shared about those potential toxicities and some of the things that we would use to manage them, what are some of the primary patient education points that we should be prepared to kind of communicate with our patients and their caregivers when they're about to start therapy with a VEGF inhibitor?
The main ones that I highlight whenever I'm doing any patient or caregiver education here is certainly the hypertension risk here, and making sure that patients are having regular monitoring of that either in our infusion or clinic spaces, or if they're not coming in, that they have the ability to have this done in the home setting, and that patients are aware of reporting high blood pressures and kind of what to watch for with symptoms here that might be suggestive, maybe a patient in hypertensive crisis. So headaches, blurred vision, dizziness, anxiety, palpitations. So those things are certainly important to report back with this drug class. And then counseling on the risk of bleeding and also that thromboembolic event. So I like to tell patients that it causes kind of both ends of the spectrum there with the bleeding and clotting, and counseling them on what to report for with those and making sure that they make the provider, the clinician team aware of that. And I think it's also important to empower patients with watching or considering the timing with surgical procedures. Some of these are elective and we know about them and we can plan ahead, but also sometimes they're not. And so we may not have the ability for that whole time. And so making sure that patients are aware of some of the concerns there is they're maybe going to be able to help to be able to communicate that in a situation where the oncology team is not able to.
Thank you so much for sharing all that. I think all those great tips and things to consider as we are counseling our patients. The surgery piece, is something I remember very closely. I worked a lot with patients with ovarian cancer. And so timing when we would start the bevacizumab after their surgery and just being very mindful of that. Or as you mentioned, sometimes surgeries are needed without expecting them. And so having to then sort of juggle what we do with that therapy as they continue. So important things for us as nurses to know, but as you just mentioned, also inviting our patients to not only be aware of those things, but sort of share that responsibility so that we can always be aware of how they're doing, what's going on in their life so that we can time their therapies appropriately. So Danielle, how do you see pharmacists and oncology nurses really collaborating and helping to manage these adverse events and toxicities for our patients? And in addition to that, also doing patient education and really just serving as that sort of trusted source of information for our patients and their caregivers?
I think there are so many opportunities here for multidisciplinary efforts and managing this. We've talked about there's a lot of these side effects that are going to be picked up front lines. Patient is in the chair, patient is in the clinic. We're identifying hypertension. We're identifying potentially some of the bleeding or the clotting risks or things that are going on there. The nursing and pharmacy teams are front lines to being able to help identify that and work with the overall team to figure out how we manage that. There are a number of drugs within this class, and there are some varying recommendations on how we manage or monitor side effects with these agents. So I think helping to identify and then helping to really pull together the literature to figure out what we need to do for a particular patient is something that nurses and pharmacists have the responsibility to work together to do. And as we talked about, a lot of these agents are oral. So these are patients that are administering them in the home setting. So working between as a nursing and pharmacy team to integrate, to have a consistent process for following up with these patients, making sure that we are getting blood pressure, monitoring back from patients, making sure that they've been counseled on all of these different side effects that we've been talking about, I think is something that can happen between the two disciplines.
So what do you see the future of VEGF inhibitors looking like in the oncology landscape? And do you see more coming down the pipe? How do you see these evolving over time?
I think one big area, and we've seen some of this just recently, and particularly in the hepatocellular setting, where we're seeing combinations of using the VEGF inhibitor class with immunotherapy. And so I think we're going to continue to see that evolve, even hearing about some bispecific antibodies that are in development where they are targeting VEGF as well as PD-L1. So getting that, again, the immunotherapy and that VEGF effects. So that might be something that we would see in the future. And then I think just drugs that are targeting different portions of VEGF. So a lot of our VEGF drugs are targeting VEGF-A growth factor, but we might see some that are targeting VEGF-C or D. So some other kind of variations of what we currently have in practice.
Well, Danielle, thank you so much for joining us again and talking about another drug class, the VEGF inhibitors. As we reach the end of our episode today, we like to always finish things off with a series of quick fire questions just to help summarize some of the things that we talked about. So to start that off, how do you think healthcare professionals can evaluate hidden or implicit bias about what they think about VEGF inhibitors?
The first thing that comes to mind for me here is that these agents are often very expensive. These are, expensive monoclonal antibodies or oral agents that many of them available just in a brand name form right now. So certainly some cost or potentially insurance status concerns here. So thinking about those socioeconomic concerns, making sure that we're doing everything we can to be able to help our patients to be able to afford these medications.
What are some common misconceptions about VEGF inhibitors?
I think in oncology, we tend to think a lot of things cause myelosuppression just because we are kind of ingrained to think that way with a lot of our medications. But I would say this drug class has low toxicity on those myeloid cells within the bone marrow. There is a potential concern for it, but a low incidence of patients having neutropenia, anemia, or thrombocytopenia.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think a really cool thing here is there is some data to show that the incidence of hypertension may be linked to better outcome for certain patients. So I think that is a really cool thing about this. And hopefully we'll see some more literature research published in that area.
What additional training or education do you think oncology nurses need to stay current on this topic?
I love podcasts. So I think this is what you're doing already is a really great way. Something that you can listen to in a commute or workout. So I think that this is a fantastic way. And then I would also just encourage signing up for FDA alerts when new drugs come through. So that's another great way of staying on top of what's out there in the oncology world.
And finally, what are some additional resources that you would recommend maybe for patients or other providers who want to learn more about VEGF inhibitors?
I am a big fan of the patient education sheets that are put together by ONS and CODA, HOPA, and ACCC. So I find them to be incredibly helpful and contain a lot of the specific details that you would need to counsel a patient on these medications. And then I think you're kind of just looking for a high-level overview of things, the ONS chemotherapy and immunotherapy guidelines and recommendations for practice. I think that text is a great place to look for kind of overview as well as some of the specifics.
Well, Danielle, thank you again for joining us. It's been a pleasure and I've learned a lot. So I really appreciate your time and just sharing all of your knowledge and expertise. Do you have any final comments to share with our listeners?
Thank you so much for having me. I guess my one final comment is a plug for, particularly with these home administered agents, is just making sure we have a plan in place for monitoring blood pressure. So considering counseling patients to get a blood pressure monitor at home or making sure that we have them coming in for regular follow-up, just so we can make sure that our patients are safely getting these medications.
Absolutely. Great recommendation. Thank you so much, Danielle. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.